Ladies and gentlemen, thank you for the opportunity to be here to tackle with this problem, drain after pancreatic duodenectomy, yes or no. I have to support the yes, and my yes will be yes, but. And why but? I want to tell you a story that happens in my unit some months ago. Maybe somebody already heard about this story. And the story is the story of this, I think, lady in the post-operative day 3 after a Whipple procedure. It's Friday morning. The lady is okay, perfect. And the drain appearance seems to be very good. And the senior assistant and the resident-in-chief look at the amylase value. Amylase value was very low. And they said, okay, time is up to retrowel this drain. But you know, despite this Friday morning, it's a bad day for the grand round, but you know, the old professor decided to have the grand round on Friday morning. And he watched to the drain. He said, yes, you are right, guys. Everything seems to go very well, but I remember this pancreas was a terrible pancreas, very soft, with a very small duct. And you know, my shaking hands was really in trouble in making the posterior wall of the pancreas. So guys, be careful, be careful. And he moved to another patient. So the assistants start to discuss about be careful, what means. The professor said neither no nor yes. And the senior assistant said, I know what is the policy if the professor say neither or yes. Wait and see. And they wait and see for the all weekend long. And you know, in the department, 3 acute appendicitis, 2 perforation, 1 abdominal trauma, etc. And the senior resident looked to the drain on Sunday morning and say, something is changing here. And Monday morning, the pus coming. And the professor said, I am a prophet. Because you know, everything seems to go very well. And you see, the complication, perhaps I am a prophet. But you know, this young guy are really very important journal, also our own journal. And they are aware about a paper published on Annal by Dr. Kawai. You can read the title. I'm going to read the title vice versa. Late removal of prophylactic drain increase the risk of intra-abdominal infection, pancreatic resection. So this is the problem. The underlying problem is the development of pancreatic fistula that we know to be the queen of the complication, the mother of all the complications. You can call pancreatic fistula, pancreatic leakage, pancreatic failure, but this is the problem. If you say yes to drain, you have to find a balance in between the advantages of the fluid coming out and the problem of the bacteria coming in. And to avoid this problem, pancreatic fistula and a good drain management is the first step for a fast-track policy in pancreatic surgery. Certainly we have improved our understanding because we are not still living in the Babel Tower, and now our language in terms of what we mean with pancreatic fistula is going to become more and more popular. Certainly this clinical and economical validation is good of this system, and we can improve this system. And probably what we have to do is to understand and better understand the role of the amylase value in the drains as a predictive factor for the pancreatic fistula development. And this is what we try to do, and we publish in 2007 Annal, look into the amylase value in drains as a predictive factor. And what we found in this group of patients, I don't go through details, but just to give the hard message coming on is that all the patients with an amylase value of more than 5,000 units on postoperative day 1 and more than 200 in the postoperative 5 develop a pancreatic fistula. And then the patient with an amylase value less than 5,000 are at low risk of pancreatic fistula. Well, based on this study and on the study I have already mentioned coming from Japan, we decided to carry out a prospective trial comparing early versus late drain removal that has been published in 2010 on Annal. And what we found that the early drain removal decreased the risk of pancreatic fistula, of abdominal complication, of any kind of complication, and look into the multivariate analysis together with an intentional weight decrease 6 months before surgery in patients. The timing of drain removal, early versus late, is a determinant factor. So if you use drain, if you say yes, please remove the drains as soon as possible, of course. I think that this is neither the true nor the life, but this is the way, because this is a good method to recognize who is going well and particularly who is going bad. We still have the problem of the so-called late fistula, and sometimes it's very difficult to understand the pathophysiological reason for the late fistula. Maybe we can find other numbers in terms of amylase value. Maybe 3,000 is better than 5,000. Who knows? We are looking at. Or maybe we are going to understand if we have some other clinical parameters. Very recently, this year, we published on pancreas this paper from Giuseppe Maleo regarding the routine imaging necessary after pancreatic resection, yes or no. And the conclusion is that the routine use of US in the postoperative course doesn't seem to be clinical relevant and does not add value to the amylase value into the drains on day 1. Moreover, we try to find other factors within the output fluid, and we look at the G-beta factor, EGF to IGF to the interleukin, but as you can see, there is no improvement compared to the amylase value into the drain. So, yes or not? This is a very famous paper published by Kevin Conlon when he was working in New York. And I say, yes, but if you use, please look to the amylase value on postoperative 1 and postoperative 3. What about the messages coming from the very recent literature? Well, we have this paper published 2013 in surgery by the group of Mustafa Adam in Lyon, in France. And this is a non-controlled trial, and the conclusion is that the routine prophylactic draining of the abdominal cavity did not decrease the frequencies or severity of the postoperative complication. And then prophylactic peripancreatic drainage also did not decrease the requirement for further interventional procedure in the postoperative period. In the same year, in our journal, HPB, has been published this cumulative meta-analysis, and as you can see, the conclusion that routine use after pancreatic resection may result in a higher risk for major complication. But evidence is not conclusive. This is another study published in 2013 on Annal by the group of Peter Allen in the Memorial Sloan Kettering, and is not a controlled trial, but they use nearly half of the time drains versus half of the time no drains, and they were associated with a longer hospital stay, higher grade of morbidity, fistula, and higher grade of readmission. And they did not decrease the need for reoperation or the need to decrease mortality rate. So prophylactic routine drainage after pancreatic resection could be safely abandoned. And this is another review published in 2003 on GSR, intraperitoneal drainage after pancreatic resection, and I concluded that the current literature supports the strategy of selective drainage and early drain removal if you use it. But let me go to the most important publication that started in 2011 in our journal, Pancreatic Resection Without Routine Drains. You see, the same surgeon watching to 180 patients, more or less, from 04 to 09, and then to 47 operated on since 2010. And the results are very interesting and intriguing, abandoning the practice of routine intraperitoneal drainage as pancreatic resection may not increase the incidence or severity of severe postoperative complication. In the commentary, my friend Peter Allen said, the Titanic is sinking. The dogmatic surgical approach is going to the end. But later on, this year, in 2013, the same group, enlarged group coordinated by Dr. Fisher, published this randomized prospective multicenter trial of pancreatic duodenectomy with and without routine intraperitoneal drainage, under title Requiem for a Clinical Trial. Because the Data Safety Monitoring Board stopped the study early because of an increase in mortality from 3 to 12% in patients undergoing pancreatic duodenectomy without intraperitoneal drainage. So this study is the first study, level 1 study, suggesting that elimination of the drain in all cases pancreatic duodenectomy increase frequency and severity of the complication. So this is my policy and our policy in Verona nowadays, depending on the value of the amylase on the first day in the postoperative course. We share our patient low risk or high risk. We are going to maintain the drains on postoperative 5 for the high risk. Look to the amylase value is less or more than 2,000. We remove or we continue drain management. But in this moment, the fistula is already evident. With this policy, we are able to recognize the patients that are going very well. And then in about 50% of our patients, we are going to apply the so-called double W rule. That means 1 Whipple in 1 week. Certainly, this is our policy, but there is another, I think, message to take home, and is for the old professor. Please avoid the grand round on the Friday morning. Thank you very much for your attention.